Secretary of your association, that's Associations of Physicians of India. And it's my proud privilege to invite you all today to this web CME, which is not only conceptualized, but also fully executed by our president, Dr. Girish Mathur, sir. My special thanks to all these guest faculty for agreeing to be here on this panel just on one email. And yes, special thanks to each one of you who have given me your time, your presence, because it's only your presence that makes this program a big success. I was talking to Wanda sir about, sir, World Hypertension Day kya hai? I'm a chest physician and I was not much aware of this World Hypertension Day. So sir told me that history of this day could be traced back to 1987. And he said when World Heart League, something called as WHL, was established under the guidance of International Society of Hypertension, it was decided to promote the public awareness, the prevention, the treatment of hypertension. And it came in 2002 that there was a proposal to make this Global Hypertension Day. And it began somewhere in 2005. Though it was celebrated for the first time on 14th of May, but since then, it is celebrated every year on 17th May. And we are here to celebrate in our small way this World Hypertension Day. During the inaugural program, the theme was simply awareness of high blood pressure. And the year after that, it was treat to the goal of blood pressure. And today, this year, World Hypertension Day theme is measure your blood pressure accurately, control it, and live longer. Today also happens to be World Telecommunication Day. And imagine what a coincidence. This day is celebrated on 17th May since almost 1969, that is more than 50 years. And today we've integrated both these events. The World Telecommunication Day, where we are celebrating the importance of communication technology and its impact on society and on economy. And look at this. We are celebrating this World Hypertension Day on the same day where entire length and breadth of my country is here. Today also happens to be World Information Society Day. Today also happens to be World Neurofibromatosis Day. Today also happens to be Emergency Medical Services Day. Today happens to be International Child Helpline Day. Today is the day where internationally we celebrate against homophobia, transphobia, and biphobia. With those words, I invite all of you and I demand your 1 hour. Give me your 1 hour and I promise that it would be one of your best time investment that you've done on understanding hypertension. That too, when you have stalwarts like Dr. Wanda, Pareek sir, Mangesh, Shashank, Dr. Tewary, Dr. Singh, and icing on the cake is going to be our president sir, who not only would address us, but also would give us his time by moderating this event. Friends, please make the best use of time. Put as many questions as you have on hypertension. And I promise that no faculty, especially Wanda sir, would be allowed to leave this stage, this screen, till all your queries are answered. So without wasting much time, I invite President sir to give his address. Over to you, Girish bhai.
Thank you, Agam, and for your very well-researched narrative on 17th May. Good evening, friends. On behalf of API and ICP, I extend a very warm welcome to all of you on this hypertension meet organized by API on World Hypertension Day. While I welcome Dr. Jyotirmoy Pal, Dean ICP, Chairpersons Dr. K K Pareek, Past President API, Dr. Kamlesh Tewary, Dr. Shashank Joshi. I think he is not here. Dr. G.S. Wander.
Shashank is there.
Shashank is there.
G.S. Wander, Director PRF, Dr. N P Singh, and Dr. Mangesh Tiwaskar. I also welcome my friend Dr. Agam Vora, Honorary Secretary API. This important worldwide activity of World Hypertension Day was created by World Hypertension League in year 2005 with the theme Know Your Numbers and with the aim to spread awareness, among the lay public about the importance of hypertension and its serious medical complications. Hypertension, as we all know, is a major global health problem. An estimated 1.2 billion adults having hypertension, most living in low and middle income countries, and is a major cause of premature death. The problem with the hypertension is that about half of the population is unaware that they are having hypertension. And less than half of adults with hypertension are not diagnosed and treated with the hypertension properly. And worst part, that approximately 1 in 5 adults with hypertension have it under control only. I'm sure with a renowned faculty on board, this scientific event will be a resounding success and will keep us updated our knowledge about various aspects of management of hypertension. I welcome you all again for this hypertension meet. I hand over to Dr. Agam Vora for further proceedings.
Thank you, sir. Thank you very much for that crystal clear message. And now we have our Dean, sir. So I would request Dr. Jyotirmoy Pal, our Dean, to say a few words.
Thank you. I congratulate entire APM team headed by Dr. Girish Mathur, President API, Dr. K K Pareek, Dr. Shashank Joshi, Dr. Kamlesh Tewary, past presidents, Director Dr. G.S. Wonder, our teacher, Director Board of Physician Research Forum, and all my colleagues, governing body member, delegates, students. Really, it is a memorable day and it is a very important day that every medical community is celebrating the World Hypertension Day. Why? That correctly told by our president to increase the awareness of hypertension. Because we clinician, we see first time patient become aware that he or she has hypertension when the patient land up with a CVA or AMI. So this is the lack of awareness, and particularly in the tropical countries, in the third world countries. We conducted one study in Bengal, where if you add the total unawareness and awareness but poor compliance, it consists of more than 75%. So hypertension is not only a medical burden, it is also a social burden. So this is why we celebrate very correctly, and we should percolate this message to the common man and population with the 3 themes of World Hypertension Day. First, measure your BP accurately, control it, and live longer. So with these few words, I hope our panelists and speakers will give a very clean-cut message to medical community and to the population, so that we can control our blood pressure effectively and we can percolate this message to community. Thank you.
Thank you, Dean, sir. Fantastic message. And now it's the time for me to invite moderator for today's program, and none other than Dr. K K Pareek, sir. Sir is the guiding force of API, currently heading the new project, that is API House project, which is taken up with a big challenging task. I must put on records that I've learned a lot under his guidance, and I would always remain grateful to API for getting Dr. Pareek in my life. With those words, may I invite Dr. Pareek. So you may have to unmute, please.
Thank you, Agam, for your kind words. And good evening, everyone. Dr. Girish Mathur, our president, Jyoti, our dean of ICP, Dr. Wander, Dr. Tiwari, Dr. Mangesh, Dr. N P Singh, and everyone who is present here. It's really a great honor and an opportunity for me to introduce Dr. G.S. Wander, who doesn't need any introduction, but as it is customary, he is one of the very renowned cardiologist and academician of great repute, not only in the country, but even outside country. I still remember my association with him as a dean and when he was president. The concept brought by him, which he discussed when I was dean, to bring out the 3 volumes of Progress in Medicine and Medicine Update, like 1, 2, 3 and volumes, and working with me and working with him was really a great pleasure, and I learned so many things from him. It was really, I cherish my memory of working with him. Dr. Wander, past president of API, past dean of ICP and director PRF, is a important leader of API. And now we'll be hearing him for the measurement and management of hypertension. And I think such activities like celebrating Hypertension Day is a great awareness among the physicians as well as in the population. But once we also learn, then we can also extend it to our patients and to the population. Awareness is the most important because still such a small thing, small little treatment, and very easy to measure it, so easy, but still, unfortunately, only less than 20% are keeping their blood pressure at a target level of blood pressure. So it is over to Dr. Wander. We'll be hearing from him. Thank you.
Thank you, sir, for the kind words. And it's always been a privilege and an honor to have worked with you in API. I am extremely thankful to President Sir, Dr. Girish Mathur, and our Secretary Agam Vora for giving me this opportunity to give some of my thoughts on hypertension. My talk will largely be based upon the Indian hypertension guidelines, since it is a day on which we have, as spoken by Dr. Jyotirmoy Pal, our Dean ICP, and others, that it's primarily a day on which actually we are trying to spread awareness of hypertension. And as very aptly mentioned by Dr. Girish Mathur, Dr. Agam Vora, the theme is to measure blood pressure accurately and control it so that patients can live longer. So that's, we'll just dwell upon some of these things. I will try to build up an atmosphere so that the panel discussion gets going, and we have some very august panelists who will then make us aware as to how patients of hypertension are best managed. This picture is very familiar, but at the cost of repetition, I would still like to make you aware, although this audience is just too learned, that after the Second World War, actually, when the world went into disarray, and people, very wise, 3 very accomplished and powerful men, Winston Churchill, the Prime Minister of UK, Franklin Roosevelt, the President of USA, and Joseph Stalin, the general from USSR, the 3 big powers at that time met together in 42. And they didn't know actually at that time that within the next 15 years, all of them died of vagaries of hypertension. So in that sense, if hypertension was neglected at about 60, 70 years back, you can well realize that how much impact hypertension has made in terms of being the commonest public health problem, because everybody knows the prevalence of hypertension in India is today 28%. There was a rural-urban difference which was more significant, which we initially used to diagnose more frequently in the urbanites. But there is a phenomenon of this rural-urban convergence which has occurred. It has occurred for other non-communicable diseases, the lifestyle disorders. So if we look at the world population, it is huge. Actually, out of a world population of about 9 billion, 1.5 billion hypertensive population. And we in India, as we sit here, we represent 18% of the world population, and 23% of the world population is South Asians. So whatever we discuss in terms of hypertension has huge implications on the hypertension prevalence control in the whole world, actually. We know as Indians, hypertension has some peculiarities, and almost half of the strokes and 1/4 of heart attacks and coronary artery disease is attributable to hypertension. Although we all know there are 9 risk factors of hypertension, of coronary artery disease, but amongst them, hypertension alone causes about 25% of patients is attributable to hypertension alone. The global burden of diseases study is huge. It has added to our knowledge in the last 6-7 years in a very large extent. And we know that 50% of the deaths amongst Indians and 1/4, that is 25% of deaths amongst the Western population is due to the cardiovascular, the cerebrovascular diseases. So obviously hypertension being a very significant factor for causing cardiovascular diseases, you can actually understand the extent to which it has bearing on the longevity of life of human beings. The GPD study shows very interesting data. Whereas 9% of the deaths were attributable to hypertension in 1990, about 17%, double of that actually are today attributable to hypertension. If you look at the terms of daily disability associated life years, it again rose, doubled from 4% to 8% in terms of what disability any diseases cause. It's not only a disease of the elderly. In fact, we looked at this data in Ludhiana and we published in 2004, we found that 4% of rural and 10% of urban children, adolescents had obesity, and 3% of them in the rural and 6% of them in the urban areas had hypertension. We went back to the same schools actually, and this work we published in the British Medical Journal. And we found that whereas obesity had increased to 10 and 20%, hypertension had increased, almost doubled to 6% and 8%. So it's not only prevalent amongst individuals beyond 30 years of age, hypertension is there actually amongst adolescents. And this is another population in which we need to actually intervene and impact and at least record their blood pressures. Well, most of the Western actually countries have their risk factor calculation method, whether it is the ASCVD calculator for the US or whether it is the score calculator or the Framingham calculation method for risk of coronary artery disease in any individual. We do not have a risk calculator for our own country. But in the Journal of Hypertension, actually, we did publish this thought process that if you look at increasing age, male sex, lipid abnormalities, smoking habit, and diabetes, because hypertension does not occur alone, it's often a component of the syndrome X. And a given individual who has multiple risk factors is obviously at a higher risk of target organ damage, whether it is heart failure, coronary artery disease, stroke, renal failure, atrial fibrillation, arrhythmias, aortic dissection, peripheral vascular disease. These are some of the consequences of hypertension. So these risk factors, when they are collectively there, people are at a higher risk. And if you look at the scores risk calculator for the Europeans, for any given risk for the Europeans, you have to multiply for South Asians, that is indirectly, actually it is Indians only, by 1.4 times. So whenever hypertension is there amongst Indians, it is often associated with other risk factors, and the risk calculation will need, just as the obesity BMI parameters are lower amongst Indians, the hypertension effects are more. And so we as physicians need to be more aggressive and more effective treatment of hypertension. Very interesting data actually, again, we published in the Indian guidelines. For the first time, Indian guidelines of hypertension 4 became internationally accepted. It was mentioned in circulation in European Journal of Cardiology and even the Journal of Human Hypertension. And you can see that whereas in 1990, the top 3 causes of death were diarrheal diseases, respiratory and neonatal birth defects, coronary artery disease, COPD, cerebrovascular disease rose to 5th level. So there has been a shift in the pattern of disease from from actually infectious diseases and poverty-related diseases to the non-communicable lifestyle diseases. And so if we have to make impact in terms of longevity of an Indian, which is 67 years for males and 70 years for females today, if we have to take it further to where it lies for the Japanese, which is 82 years, whereas an average Englishman has a longevity of life of 79 years. So we still need to work a lot in these non-communicable diseases because we have to look at our patients individually. Our patients are not different. And that's the reason actually we all realize that hypertension, yeah, can you please put your phone, off, occurs relatively early amongst us. I did mention this, the rural-urban divide convergence is now seen. I already mentioned there is clustering of multiple risk factors. There is seasonal variation. And we know that the average blood pressure in our population is increasing. This is some work that we published in Indian Heart Journal. We are going through summer now in northern part of India. And we looked at, we all actually upregulate therapy in winters and we downregulate therapy amongst our patients in summers. And this is what we documented actually, that this was more marked in rural patients, the elderly individuals, this seasonal variation was even higher, and this needs to be kept in mind. The actually pollution is a huge factor, and you can see the dark color seen around the Indian map. So we have one of the highest PM 2.5 levels in some parts of the year and almost throughout the year. So pollution plays a huge effect in terms of increasing occurrence of these non-communicable diseases. And so also increased salt intake. One of the ICMR studies actually showed that an average Indian takes 8 to 11 grams of salt, whereas the guidelines suggest 5 grams of salt. So we need to make a lot of difference in terms of our lifestyle, which needs to be aggressively pursued. One of these very important trans-ancestry genome-wide association study actually looked at some of what are the genetic markers of hypertension, and we could find 12 new loci which were associated with hypertension. And there was especially a role of DNA methylation in blood pressure regulation. And we all know Indians genetically are different. South Asians have higher prevalence of this thrifty gene. And so the Indian hypertension guidelines actually mention a lot of these. This is what we have actually put in terms of normal category, optimal blood pressure, normal and high normal. We do not use the term pre-hypertension, something that was used by the US guidelines. You keep adding 10 to the systolic and 5 to the diastolic in the normal range. And we have stages of hypertension. We realize that systolic hypertension is more risky than diastolic. Its prevalence is increasing to a larger extent. Elderly have more of systolic hypertension, whereas younger people have more of diastolic hypertension. So systolic hypertension figures separately amongst our actually guidelines. This is, I just thought it's very familiar to you. The American guidelines have actually 10 millimeters less pressure. That is, hypertension is defined as a pressure of more than 130 by 80. In fact, they mention what is the high normal for us in Indians. They have put it as stage hypertension 1, and beyond that, they have just put it as stage 2, whereas we in the Indian guidelines actually mentions stages 1, 2, and 3 for definition. So this is about the definition. We in the API and also in the HSI have been emphasizing home measurement of blood pressure, something that has been missing. But one needs to keep in mind that the pressure of 135 by 85, this is the level which will define hypertension, whereas in the office, a pressure of 140 by 90. Patients often come to us and tell us that their pressures were less at home. And we need to tell them that, yes, the medical world is aware that pressures at home are less, and even the level at which we define hypertension. Ambulatory blood pressure is now being used more often. These are figures for 24 hours, which are actually 130/80. The daytime pressures are similar as home, and we know nighttime blood pressure. So these are some of the levels which a physician needs to keep in mind. The inter-arm blood pressure actually is very important. And this is some work we published in Journal of Clinical Hypertension, in which we did show in a very large population of more than 1 lakh patients that there is a difference in the blood pressure, and patients need to be told that first time they go to a physician, blood pressure is to be checked in both the arms. About 6% of them have a difference of more than 10 millimeters of mercury. And the arm which has the higher blood pressure is the arm which is the representative arm, and that is the blood pressure which is to be taken. Postural blood pressure recording, postural hypotension are very important aspects which as clinicians we need to keep in mind. Couple of years back, we used to say there is no Indian data, but there is such huge data, just as I showed you previously, study of 1,30,000 patients. This is another 18,000 patients were actually undertaken in the India heart study. And what we found actually is patients who were various class of hypertensives, that is white coat hypertension is seen in about 14%. White coat is when blood pressure is more in the clinic, and at home the patient is finding normal blood pressures. Sustained hypertension is the prevalence is this, and masked hypertension, something that needs to be emphasized amongst Indians. The prevalence of masked hypertension is very high. Masked hypertension is when in the actually clinics we are getting normal pressure, but at the home the pressures are more. So both these entities in our clinical practices we need to keep in mind, the white coat hypertension, and so therein lies the value of actually good office readings which are taken in a calm, quiet environment. 3 readings to be taken, the second and third average to be taken, and of course masked hypertension, because the risk of masked hypertension is even greater than sustained hypertension, because these people are often left and they are not treated. We actually published last month only the approach and attitude of physicians towards home blood pressure monitoring. We do know that almost 90% of us are recommending home blood pressures to a patient, which is something very nice, but only 1/3 of our patients own a blood pressure device, and only 1/3 of them actually measure home blood pressure. Patients need to be told that they should not react to a single reading. Very often we find problems, patient gets one reading. Blood pressure is a lay-by recording, and blood pressure can vary within a range of 30 to 35. We need to spend time with our patients rather than telling them not to record home pressures. The diabetologists have done so well in this respect. They need to be told that average of 7-day reading is to be taken when we are looking at home blood pressures. And of course, it needs to be encouraged. Most physicians actually had some confusion because most guidelines also do not emphasize the home blood pressure levels to that extent. And the barriers we found in this particular study, actually last month only this has been published, were lack of guidelines, lack of understanding amongst physicians and patients. The reliability of devices, of course, is a very big issue in our country. I will dwell a little bit upon this issue because measurement is one of the themes, and Dr. Girish wanted me to speak to a significant extent in terms of measurement, and of course, cost is important. The Asian Home Blood Pressure Monitoring Survey was published in a very high impact journal, the Hypertension Research. And if you can see here, how we figure as compared to some of Japan and Singapore and Taiwan, some of the more developed countries out of Asia, almost 1/3, 30% of them, our patients are measuring blood pressure. And those who have apparatuses, almost 1/4. So we need to actually work a little bit more in this. The home and the office blood pressure, single reading, no one should react to that. Multiple home readings, multiple office readings, that is how we should manage our patients. And again, this particular survey, all across Asia, it was seen that only 1 in 5 physicians correctly answered 135/85 as the diagnostic threshold for. This is a large ICMR study which we did here many years back actually, And we did publish this study, and we found that although the knowledge of physicians in terms of blood pressure, this is about the office actually blood pressure reading. Although the knowledge is very large, the practices are actually, so the Indian guidelines mention how blood pressure should be recorded. One should not have had tea, coffee. One should be resting for a while, mentally peaceful, not very crowded, not very noisy. And that is very important. We also know that the Minamata Convention, actually India is a signatory to the Minamata Convention, and the mercury sphygmomanometers will have to be done away with by 2022. Actually, that is what we signed. Now we are on an extended phase. So the mercury sphygmomanometer actually has to be discarded, and we have to use the other equipments. Although in this survey, which we published in the Journal of Blood Pressure Monitoring, still 82% of Indian physicians feel that the most accurate BP device is the mercury. And when we asked them actually that which is the most robust device, half of them believed in this. And so this kind of feeling needs to be actually dispelled from the physician's mind also. They need to realize that mercury has to be given way, and we have to use the aneroid or the digital, the standardized digital. The problem with aneroid blood pressure apparatus is that every 6 months it needs to be calibrated. And the problem with the electronic blood pressure apparatuses is that they all have their own algorithm. Actually, they do not measure the systolic or the diastolic blood pressure. They only measure the mean blood pressure. And every company has its own algorithm, which they do not put in the public domain. And we don't even know actually. So the electronic equipments only of very good standardization actually should be used, because they can be very folly. And in this term, actually, we worked with the team from IIT Ropar, and we came out with this Oscar-D, a digital blood pressure apparatus now, which is published in the Journal of Medical Engineering and Technology. And clinical trials were actually used, and now digital blood pressure apparatuses are being used in our country quite extensively. This is one other project which we have taken in the last couple of years to develop a mercury-free sphygmomanometer, because mercury, there's nothing wrong with mercury as a device, as actually a material to be used. The problem is, as they found in Minamata, that it causes, and even in Kodaikanal in India, there was a lot of neurological effects, because mercury is actually a reservoir of heavy metal, and the fish eat it, and then people get affected by mercury toxicity occurs when people consume that fish. And so we thought, can we use another material? And we looked at actually this material Galistin actually, and we found that Galistin somehow sticks to the glass volume. So then we actually treated it with hydrochloric acid and sodium hydroxide, and we found that this stickiness actually could be handled when we use Galistin in place of mercury. The problem is that the Galistin is actually half as dense, as its viscosity is half as dense as mercury. So if we have to develop a blood pressure apparatus which is to be used in the office with Galistin, it is to be double in height in terms of its height, because its viscosity is half. But we did publish this concept hardware development of and we used it in about 250 patients in our institution. And now a patent is actually filed. So hopefully in the next couple of years for your office, by the time you get away with the mercury sphygmomanometers, the Galistin is there actually, which can be developed. This is the other actually in the measurement arena, the automatic office blood pressure apparatus, which actually obviates the stress that a white coat causes. So the patient sits in a calm room, the physician may be away from the patient, and it takes 3 readings. These are the various devices actually which are already available. We all know actually True BP was used for a long period of time, and now some of these other devices are there. This particular device was used in the sprint trial, and one of the reasons people feel actually sprint blood pressures control levels were lower, and people feel the reading of a usual office blood pressure is about 5 to 8 millimeters of mercury more. So this is recommended now in the Canadian guidelines, not so in the US and Australian. And we have also not actually, because these are expensive equipments. Coming back to the treatment of hypertension, of course, I think this August audience knows a lot, but I'll just touch upon some of the aspects which the Indian guidelines have been emphasizing. You will get the salt content of most of the actually food items so beautifully from the Indian guidelines. These are some of the things that you consume on a day-to-day basis, and these are high salt. So you will get an idea as to how lifestyle modification, regular exercise, weight reduction. One of my teachers used to say alcohol is the most important reversible cause of hypertension. Then smoking cessation, weight reduction. All these are very important aspects which are dealt with in the Indian hypertension guidelines. A simplistic algorithm, the ABCD algorithm, which is there in the Indian guidelines, mention that A is ACE inhibitors or receptor blockers. Younger patients less than 55 years, this is how we start. Older patients more than 55 years, you start either with a calcium channel blocker or a diuretic. The treatment of hypertension today is significantly changed in the sense that we use combination therapy more often. In fact, the International Society of Hypertension guidelines say as the first step, you can use a combination of A and C or D. In the Indian guidelines, now we emphasize if you have to further go up, if the blood pressure is not controlled with 2, you combine A with C or D, that is a calcium channel blocker or a diuretic. The third step is you combine the 3 together, ACE or an ARB. You never combine an ACE and ARB together. And ARNIs are not treatment for hypertension. ARNIs are actually only for heart failure as yet. So don't use ARNIs for hypertension alone, but you combine an A with C and D. And this is very important. I'm sure this is known to all of you. As a fourth agent, it's the mineralocorticoid receptor antagonist, spironolactone, which is to be used. We have many triple pills that are available. And of course, beta blockers, as you can see, have been relegated to this step 5. There has been actually a significant change. The American guidelines, the ACC/AHA don't even mention them as first-line agents. We in India do mention them as first-line agents because we believe that for young hypertensives, for coronary artery disease patients, migraine, heart failure patients, and some people have as such an increase. A lot of people believe that Indians have increased sympathetic activity because the baseline heart rates in the India heart study actually were about 8 to 10 per minute higher amongst Indians, whether it is to younger age, deconditioning, whatever, that is debatable. But I just wanted to share that they do not even mention beta blockers, although we have seen a rise and fall of beta blockers. We do mention in our guidelines very important aspect actually, which are the desirable and which are the undesirable combinations. Beta blocker. So 2 drugs from the left, that is those which hit upon the increased renin activity or the increased sympathetic activity, should preferably not be combined. So combine an ACE with C or D, combine an ARB with C or D, and beta blockers and centrally acting drugs, of course, are not good combination. We know 2 drugs from the same class should never be used. Beta blockers should not be combined with verapamil and non-dihydropyridine calcium channel blockers because they all affect the conduction system and they can cause bradycardia. This is very unique feature of the Indian hypertension guidelines in the sense that we have given a range. Blood pressure never stays at one level. The most significant thing the European guidelines did over all previous guidelines was they gave a lower level, that is, do not bring it below 70 millimeters of mercury. So for the first time, this concept of actually the J-shaped curve, the Cruikshank's curve is known to everybody. But for the first time, they laid this lowest level to which you should bring. And the Indian guidelines have now given this particular range that how aggressively you should treat blood pressure. And of course, we know in elderly people, we are almost as aggressive, although we look at their postal blood pressures. So when the European guidelines, when the American guidelines were published, we actually published an editorial in Circulation looking at the global impact of 2017 American Heart Association guidelines. And we did emphasize, actually, I quote from that editorial, to achieve improved control of hypertension, countries should adopt and enforce hypertension screening and diagnosis programs. This is what is going to. Dr. Girish Mathur mentioned in the beginning that half the people don't even know they have hypertension. So these screening, I think API, HSI can undertake screening and diagnosis program on a national level. We have the May measurement month, and I know we have been participating, API has participated and even published in the May measurement month of the of the Hypertension League, and we need to actually pursue this to a larger extent. Similarly, when the European guidelines came, in the European Heart Journal, we published this editorial in which we emphasize that protocol-driven standardization of treatment. Hypertension treatment is very simple actually. Today it comes down to an ACE-ARB or a calcium channel blocker as the first line, or a combination as the younger patient you prefer ACE, and elderly you prefer a calcium channel amlodipine or a diuretic. So protocol-driven, have a simplistic protocol, that is what is going to make a bigger difference. And in fact, the Indian National Program on Prevention and Control of Cancer, Diabetes, Cardiovascular, Stroke, I come to almost my last 2-3 slides now. The target is to reduce by 2025, 25% reduction in CVD deaths and 25% reduction in prevalence of hypertension. And this can only happen with better diagnosis and better lifestyle modification. The Indian Hypertension Control Initiative is a beautiful initiative which has been started by the Government of India, and some of the initial publications have come out of it, and we should all be aware of it. It was initially started in the public sector, and in this beautiful, it was first started in these 4 states, Punjab, Madhya Pradesh, Maharashtra, and Telangana, and they did show something very interesting. At registration, 26% had control, and on follow-up, 60% had control. Dr. Girish told beautifully that 20% of urbans and 10% of ruralites have their control. But if you look at this interesting, in secondary care facilities, the control rates were less than in the primary care facilities. And so this Indian Hypertension Control Initiative has now actually, our center is the first private sector institution, because 70% of hypertension is being treated by the private sector. So the ICMR has been made to now realize, in fact, yesterday a team of ICMR was here with us, and these are some of the initiatives we have taken in our own city to mass. Actually, we have gone to this Chamber of Indian Industries and various industrial groups. Actually, this is something that needs to be done. The IMA needs to be taken into actually in the loop, so that we can impact and spread the awareness of hypertension. Of course, this is a project which will then be replicated in other private sector institutions. We have done initial prevalence studies on this. And I have a proposal actually, since we have all the top API office bearers here. This is a big CSI Great Indian Blood Pressure Campaign, which was a one-day survey actually. And some of us participated in this, a very large number, about 1 lakh of patients on a particular day. The prevalence of hypertension was studied. The mucormycosis registry is almost complete now. And if everybody agrees, we can actually do an API HSI survey on the profile of hypertension in India. I'll just take half a minute more. This is proposed to start this year under the aegis of API, ICP, and TRF. 500 physicians from across the country will provide data on 300 consecutive patients, which will make it 1 lakh patients. Data on 1 lakh individuals. And this survey will look at the level of control our patients have, the concomitant diseases they have, the compliance of our patients, choice of medicines which physician. It's just a survey actually, nothing. We are not intervening. Target organ effects, home blood pressure usage, a very simple 1-page pro forma will be there. And hopefully this will be the first survey to be done under the, we already have the registry, the mucormycosis registry, which is almost complete, and those publications are going to come up. This is the last slide actually. The Indian Hypertension Guidelines, you all know some of the stalwarts are here who have been participating in this. They came up in 2001 and the Prime Minister released these guidelines at that time. The second Indian Hypertension Guidelines were released in 2007, which is about 5 to 6 years later. The third Indian Hypertension Guidelines came in 2013. These are in fact the most legitimate and widely used hypertension guidelines in the whole of Asia. The fourth Indian Hypertension Guidelines came in 2019, another 6 years. And friends, I would like to end here by saying and requesting, it is time for us to start the Indian Guidelines on Hypertension 5. And hopefully, if everybody agrees, the President, sir, actually decides, and Dr. Pareek sir gives his patronage, these guidelines should be released at the next API, because it's almost the same interval as we have been actually bringing out our guidelines earlier. Thank you very much for the patient hearing, and look forward to the panel discussion, sir.
Thank you very much, sir, for that fantastic presentation. And I'm sure Pareek sir and President sir, Dean sir, and all solvents here are going to take up your suggestions, your guidance, and we would definitely start working on coming out with these newer guidelines. I'm sure everybody will have a lot of questions, a lot of points to discuss, a lot of clinical situations to probably narrate, and let's make it very interactive session. Let's understand the practical or the real world issues that you and me face in managing hypertension today. So for that panel discussion, I have a fantastic panel here, and it's my proud privilege to invite Dr. N P Singh. Pareek sir is already here. Shashank is here. Dr. Tiwaskar is here. Dr. Kamlesh Tewary is here. And I would request President sir to say a few words, make his comments, and then please start with the panel discussion.
Thank you, Agam. Thank you, Dr. Wander, for a superb talk on hypertension measurement and management. I think he covered almost all the aspects of management. And in my opinion, there cannot be a better person than Dr. Wander to speak on hypertension. He is a key person behind the Indian guidelines on hypertension. And I welcome his proposals for the API HSI survey and the 5th Indian guidelines on hypertension. I think we will work on that. So now we move on to our second session of the program, panel discussion. And I request our chairpersons to introduce our panelists. I request Dr. Kamlesh Tewary to introduce Dr. N P Singh and Dr. Shashank Joshi to introduce Dr. Mangesh Tiwaskar.
Dr. N P Singh, he is a known nephrologist and topmost nephrologist in India. He's Professor of Medicine and Dean Medical Research Society, HGT Medical College Hospital and Research Institute, Budre. He is a governing body member, actually Vice President of the Association of Physicians of India, and he is a very nice person. This session does not know much about N P Singh because everybody knows him. So I think he can start with comments on the questions asked by him. Dr. N P Singh, please.
Thank you, sir. I will request my panel in charge, Dr. Girish Mathur, to kindly initiate the discussion, and then I'll answer the questions.
Dr. Singh, my first question to you is, what should be the blood pressure goal for patients with chronic kidney disease? And what is the appropriate treatment for patients with stage 3rd or higher chronic kidney disease?
Very, very appropriate, sir. In fact, CKD and hypertension are almost similar to each other in the sense that almost 80% of the patients with chronic kidney disease have some form of high blood pressure. High blood pressure can contribute to chronic kidney disease and vice versa. We know some of the mechanism which Professor Wander alluded to includes volume expansion, which is the only reason in acute kidney injury. While in chronic kidney disease, apart from volume expansion, there is renin and angiotensin stimulation, and also there is increased sympathetic activity, which has been well known to contribute immensely to what is known as resistant hypertension. Of course, we have certain peculiar situations like secondary hyperparathyroidism, which can cause increase in the intracellular calcium, which can also contribute, and erythropoietin, which is a key factor in management of anemia, can also contribute. So we have multitude of reasons for high blood pressure in chronic kidney disease. Now, as far as the target goals are concerned, there have been a number of guidelines which have clearly shown, including the major sprint guideline, which was released a decade earlier, has clearly shown that the lower the better. Now, that is true for patients with chronic kidney disease. However, especially in patients who have proteinuria, that is, who have a protein content of more than 1 gram in the urine, are likely to benefit from the management of hypertension. So we normally say that the blood pressure goals, as suggested by Dr. Wonder, should be around less than 135/80. And unless the patient is very old, has extremely additional comorbidities, and the longevity is there in succession. And as far as management is concerned, there is a now universal acceptance of the fact that ACE inhibitors and ARBs are the key drugs which can not only contribute to decreasing proteinuria in patients with chronic kidney disease, but they also have been shown to prevent the progression of chronic disease and, more importantly, protect us from cardiovascular morbidity and mortality. So ACE inhibitors and ARBs continue to remain the first drug of choice. There has been a lot of concern about their continuation in further late stages of chronic kidney disease, CKD stage and 4-5. And the STOP CKD trial in UK has clearly shown that there is no benefit of stopping the drugs in the late stage of the disease, unless there are very, very clear-cut indications of a very severe hyperkalemia or a worsening of the renal functions. So we need to continue with these drugs. Apart from ACE inhibitors and ARBs, based on the other comorbidities, the patient has a volume overload, then diuretics contribute. And we all know that these patients actually require at least 3 or 4 drugs to control their high blood pressure. Non-hydroxyapatite calcium channel blockers like diltiazem have also been shown to not only reduce blood pressure, but also decrease proteinuria in chronic kidney disease patients. So the target has to be trying to bring in drugs like ACE inhibitors, ARBs, calcium channel blockers, a combination as was shown, and also a diuretic. Now, if in case the patient is not responding to these 3 initial combination, then the role of mineralocorticoid receptor antagonist does come. They also have an impact on preventing the chronic kidney disease. And the only issue is that we need to be very vigilant and monitor these patients for hyperkalemia. Now, hyperkalemia also was considered as a huge concern earlier, but now we know that there are other ways and means by which we can reduce the serum potassium level by reducing the potassium intake in the diet, or by giving them binders or a bit of a diuretics, and not withdrawing the ACE inhibitors and ARBs, which have been immense benefit. Now, on top of this has come in last 5 years the role of SGLT2 inhibitors. We all know this very well, whether diabetic or non-diabetic. Recent trials have clearly shown that these drugs have now a role to play in not only preventing the progression of chronic kidney disease among diabetic population, but also non-diabetic population. These drugs, through their multitude of action, can impact the progression of chronic kidney disease, protect you from the heart. Now, remember, all patients with chronic kidney disease do not actually succumb to the disease because of the progressive renal failure, but they go to Dr. Wonder and die of cardiovascular disease. So there is a need for us to now, as Dr. Wonder was mentioning about the Indian guidelines, I think we need to develop certain evidences about these newer molecules, especially the SGLT2 inhibitors and the mineralocorticoid receptors, regarding their role in Indian subset of patients, so that we can come to a logical conclusion about their role and their use in our patients. Thank you, sir.
Thank you, Dr. Singh. That was fantastic answer. I think you covered the entire aspect of renal failure and blood pressure management. And the next question I would ask Shashank. Shashank, are you there? Now, Wanda sir has given clear-cut idea about initiating antihypertensive therapy, but in real world, there are so many situations where, say, for example, I have a patient who's got dyslipidemia with, say, what do you call it as metabolic syndrome. Would there be any different choice of antihypertensives? Shashank, over to you. Unmute, please.
Shashank, you have to unmute. Shashank, unmute yourself.
Am I audible?
Now, yes.
Yes.
Yeah. Agam, your question was, if there is a setting of dyslipidemia with hypertension, will the antihypertensive therapy differ?
Yes.
So there are some antihypertensive drugs, particularly the older drugs, like the old generation beta blockers and the thiazide diuretics, which definitely were having an adverse impact on the lipid profile. But the modern generation antihypertensive drugs are lipid neutral and lipid friendly to a great extent. So from that standpoint, it's a separate issue. But I would like to contextualize it in a different way. Most people who have hypertension or type 2 diabetes are at a cardiovascular risk continuum. And you did make a passing mention of the word metabolic syndrome. So in them, probably keeping their LDL cholesterol below 50 or 70 is that of order. And therefore, giving them a statin on board to stabilize an unstable plaque is usually in order. So I think, independent of the antihypertensive medication, I think one should keep a hypertensive patient on statin, because the risk of a cerebrovascular accident or a cardiovascular accident is pretty high in people living with hypertension. And therefore, stabilizing their plaque and keeping them an LDL to target below 70 is in order. So that's one perspective. And some of the antihypertensive drugs, particularly of the older versions, like thiazide diuretics, can be lipid adverse, and therefore one has to be mindful of that. I hope that answers your question.
Thank you, Dr. Shashank, for the wonderful explanation. I would now Dr. K K Pareek, a renowned expert on hypertension and diabetes. Dr. Pareek, sir, in patients with diabetes mellitus, when should we start antihypertensive drug treatment, and how coexistence of diabetes affects the hypertension management?
Thank you. Very appropriate question. Because every third or fourth patient which comes to our OPD for consultation suffers from hypertension and diabetes, both the common disorders which are there. And it keeps this group of patients of diabetes and hypertension in a special situation, because the increased risk for micro and macrovascular complication are there, but the risk for cardiovascular risk is much more, many times more than others when a diabetic patient is having hypertension. So we have to look for these patients very especially, because they have got nighttime rise of blood pressure. They are more salt sensitive. The response to the antihypertensive drug is very difficult. We need 3 or 4 molecules of antihypertensive drugs. There is a postural hypotension. There is a increased BP variability. So, and systolic hypertension is more dangerous in these patients of diabetes and hypertension. So we look for all these problems, and we have to manage in these patients. And the blood pressure, with all guidelines, the target blood pressure in patients with diabetes and hypertension, when we should start treatment or pharmacotherapy, is above, when blood pressure is 130/80 or above. The target of keeping blood pressure below 130/80 should be our target of keeping blood pressure in a patient of diabetes and hypertension. In 2023, the recent guidelines of ADA, which also says that blood pressure should be 130/80, but the Indian hypertension guidelines, what it says that we should wait for 3 to 6 months if there is no risk for cardiovascular disease, or if there is a calculated less risk, then we must ask a patient for lifestyle modification, and we must wait for 3 to 6 months. We must ask for all kind of total modification in lifestyle, like DASH dieting, cessation of smoking and alcohol, good night's sleep, DASH increased physical activity, and so many things that we are part of lifestyle modification. But all the total lifestyle modifications are more important, not its one part or second part. So all guidelines are in favor of keeping blood pressure level 130/80, less than 130/80. But if one cannot tolerate in elderly patient, the blood pressure, according to the European guidelines, we can be even kept at the below 150/90, because there are so many complications in elderly patients. There are so many comorbidities. So there is a possibility of postural hypotension also. In all these patients of diabetes and hypertension, we must also look for postural hypertension, because of the diabetes, the autonomicity, there is a chances of postural hypertension. So this is my, and then the last thing that I would say, that individualization is the most important thing. We must look into all these things, whether the patient is suffering from other comorbidities, so many drugs he is taking, frailty, and there, I mean, we must involve the patient, and it should be a teamwork, and a clinician and a patient should be involved in the decision making. So it is not the, we must also look for the individual patient, not for that we should go for according to the guidelines, patient tolerance and other things also, patient's affordability. What I feel that to reduce blood pressure is more important than thinking of suitable antihypertensive drug for any patient, because the patient cannot afford a drug and he stops after 2 months or 3 months. Then whatever may be the medicine, available medicine, our aim should be to reduce blood pressure, and so that we can reduce the complications also. So then if patient can afford, then we can ask for the right medicines for that. But the first aim should be that at least blood pressure should be reduced to a normal level. So according to my last say, to conclude my answer, all guidelines says that the blood pressure treatment should be pharmacotherapy should be started at a blood pressure more than 130/80 or more. But according to the Indian guidelines, I think, and European guidelines, it is 140/90. Below 140/90, we can, above 140/90, we can start treatment for hypertension. Thank you very much.
Thank you, sir. That was fantastic explanation. What you said is patient must be involved into decision making. The cost factor must be kept in mind, and you stressed upon the lifestyle modification, which is very easily spoken but very well forgotten in practice. People don't mind starting 3, 4, 5 antihypertensives, but somehow this point is missed. So thank you very much for
Thank you.
bringing that. And Mangesh, I think it's your time to wake up now. And we had discussion on hypertension with renal disease. Sir spoke about hypertension with diabetes. Shashank spoke about hypertension with dyslipidemia and metabolic syndrome. And I have a question for you about diabetes and stroke, or say cerebrovascular accident. Would there be any different considerations in choosing antihypertensive if patient has got associated stroke or cerebrovascular accident? Over to you, Mangesh.
Thank you, Agam, and a good evening to everybody, and compliments to Dr. Wonder, sir, for a superb work he has done in the hypertension field especially, and the way he has entirely delivered today's session. Now, Agam, यार मेरे को ये difficult questions तो मेरे को ही क्यों पूछता है? Wonder sir है.
I get sadistic pleasures.
So, but I can tell you, whatever we have learned from our neurology colleagues, even though I am not a practicing neurologist, but we deal in with such kind of a dilemma, especially in our ICCU patients. And that is the place where probably this very gray area in the hypertension management actually comes to the play. Now, as far as the question is concerned, is absolutely valid, but we need to understand that what type of the stroke you are, dealing with. Is it stroke prevention that you are talking about? Are you talking about an hyperacute or an acute stroke, which is ischemic, which will be calling for a thrombolytic therapy or a thrombectomy, or you don't aim to do that? Whether it is a stroke in evolution, developing stroke, or a subacute stroke, or are you talking about the hemorrhagic stroke? So the first message is this, that clearly identify the cause of the stroke, because the cause of the stroke will decide the definite blood pressure targets. Overall, as the consensus agrees and most of the guidelines agree, including the European Stroke Society agrees, that the target always has to be less than 140 or 90. But the difference here is that how quickly you would like to achieve. And especially when you are treating the patients of the stroke, when you are dealing with the patients, those who present to you with the stroke related accelerated hypertension events. So if it is an ischemic stroke and you are aiming to thrombolize the patient, before thrombolysis, the ideal target should be a systolic of 185 below and 110 diastolic and lesser than that. And when you thrombolyze the patient with altiplase, probably the target should be lower than 180 or 105. If you're planning a thrombectomy on the patient, then probably the target should be less than 180 or 105. And then you should start reducing down the blood pressure with the rate of around 15 to 25% in 24 hours and try to reach the target in coming 2 to 3 days. Acute lowering of blood pressure is generally not recommended, especially in those patients, those who have an ischemic stroke. As far as the hemorrhagic stroke is concerned, we need to understand that whenever you are treating the patients of hemorrhagic stroke, if you acutely lower down the blood pressure, it will definitely reduce down the clot or the hematoma, but can also worsen the perfusion. So there also, the rate of reduction of blood pressure needs to be around 15 to 25%. But in a certain select scenario, like suppose somebody has an associated heart failure or an acute myocardial infarction, or probably any other reason that calls for an abrupt reduction of blood pressure, it should be done with an intensive monitoring with a proper management of all the comorbidities and including stroke. That is what is the answer to your questions.
Thank you, Mangesh, for answering a very difficult questions put by your friend Agam in a more simplified manner. Thank you so much.
Thank you. Thank you.
So now I come to Dr. Kamlesh Tewary. Sir, how should we approach managing hypertension in pregnancy? And what are the drug of choice when you treat hypertension in pregnancy?
Sir, hypertension in pregnancy has got different variants. Number one is chronic hypertension. I mean, lady is suffering from hypertension before pregnancy, and she is going to pregnancy, that is chronic hypertension. Another is gestational hypertension. Hypertension developing for the first time after 20 weeks of pregnancy or before 1 week of delivery. That is gestational pregnancy. And both conditions can go into retoxemia and toxemia. So it will depend. But for the treatment point of view, bed rest is must if patient is in hypertensive emergency. Bed rest is must. Number two is salt restriction or lifestyle modification, you can say, is must in those patients. Though she can't do all the exercises, but diet restriction and some exercise must be given to the lady. And regarding drugs, previously methyl dopa was the drug of choice in that condition, but methyl dopa is not available throughout the country. Actually, we are not getting at least methyl dopa here in our part. So choice is labetalol. That should be given, and that should be the ideal drug. Hydralazine, not very much used orally, can be used intravenously in different situations. So labetalol and calcium channel blocker, especially nifedipine, can be given orally. So nifedipine should not be given sublingually as it was practiced in the previous days. No, don't use it sublingually. Choice is labetalol most of the time. Sometimes you can use calcium channel blocker in the form of nifedipine or other calcium channel blocker, which is not going to harm in the pregnancy. If blood pressure goes high, if patient goes into eclampsia or preeclampsia, then we have to give IV drugs. And in IV drugs, preferred drug is again labetalol or hydralazine is there to give IV, or sometimes sodium nitroprusside, which is not recommended and not available everywhere, and it is causing fetal toxicity. It is not recommended. So labetalol is still the best drug to give intravenously in case of emergency, in case of high blood pressure. So these are the drugs which should be given.
Thank you. Great. That's a lovely explanation. Mangesh, you have a point to make?
No, I have a questions to ask, and I want to ask Dr. Wonder sir what my doubts. Best moment for me to ask and clarify my doubts on a couple of things. Sir, you spoke wonderfully well about all the possible pharmacotherapies, but I want to have your serious and a very honest opinion as far as beta blockers and especially the cardiac selective beta blockers and their role. And I also want to ask your very honest opinion on, even though we recommend diuretics in the elderlies and especially people above 75 years or 70 years, even though they are high, thiazide or thiazide-like diuretics, what is your take on their safety and their effectivity? Beta blockers use in the Indian population.
I think these are very pertinent questions you just asked because they bother every practicing physician. You are of a young age, but especially people of my age, it really bothers to a larger extent because the first drugs were beta blockers and diuretics. And that's why called the conventional. And Shashank did mention that they have metabolic side effects, the lipid disorder. And one thing is very clear that a combination of a beta blocker and a diuretic should never be used. You know it better than others that new onset diabetes was very common. The percentage is very high actually. So that combination actually, especially atenolol actually is blamed as an agent rather than as a class effect. I fully agree. In fact, we debated to a very large extent, and you were also there actually when we formed the Indian guidelines. And the consensus was, as I said, the India heart study also showed that the heart rate of Indians are about 7 to 8 beats per minute higher as compared to the others. And the European guidelines actually also include beta blockers amongst first-line agents. But yes, the role of beta blockers as first-line agents in hypertension is actually now gone out of vogue. Firstly, for the increased diabetic effect. Secondly, lipid. Shashank touched upon that, the hypertriglyceridemia. And third is that the most important factor is actually the life study data, which showed that this was actually the first study in which head-on atenolol was compared with losartan. And you know that the central blood pressure is not reduced to the extent that the central blood pressure is reduced by other antihypertensives. So although we might be complacent that we are reducing pressures, but so in that sense, although the role of beta blockers as heart failure agents has gone up today, every heart failure, whether it is stage 2, 3, 4, whatever, our endeavor is that all these people should be put on beta blockers. At the same time, role of beta blockers in treatment of hypertension has gone down. Having said that, yes, there are subsets. As I said, 4 of these: patients with coronary artery disease, patients with heart failure, patients with concomitant diseases like migraine, and young individuals with increased sympathetic activity. These are the subset of patients where hypertension can and should be used. But elderly people with no other disease in which which is going to be benefited by beta blockers are certainly not. A lot of people, as I said, believe all this. The reason beta blockers have gone into disrepute is because of the atenolol, since this is the agent which was used. In fact, way back in late 80s and 90s, Maffei's study and other studies, they used actually metoprolol. And metoprolol data was not as bad as actually the data with atenolol was. And a lot of people today believe that some of these newer beta blockers, so to say, nebivolol, which is the most cardioselective beta blocker, bisoprolol, which is the second most selective beta blocker, and carvedilol, which has intrinsic sympathomimetic activity, as Sir was saying, individualized. So beta blockers, if they have to be used, the whole patient's thing needs to be taken into its perspective. Yeah. Second part you asked, I'll just quickly answer. I'll not take more than a minute. Diuretics. Yes, diuretics last. Actually, a couple of years we were told that chlorthalidone is better than the other thiazide diuretics. But last year there was a very big, huge study which you are aware of, which showed that in people who do not have other diseases, the thiazide-like diuretics, that is hydrochlorothiazide, which is most commonly used and cheaper, is as good as actually chlorthalidone. Yes, the metabolic side effects are less with indapamide. And so you need to actually individualize. it is today actually mentioned in all the guidelines that as a third agent, diuretics must be used because they have a synergistic effect in management of hypertension. So as an add-on agent, thiazide diuretics are very good. Today we know actually after the MRFIT trial that hypokalemia occurred actually that we need to use lower dosages of thiazide. So when they're used appropriately in combination, they are excellent agents because they bring down blood pressures. And one of the most beautiful line I think today, which somebody, I think Pareek sir mentioned, the AllHat study showed us that all this thing we keep lamenting about metabolic friendly, unfriendly, it's the level, it is the pressure.
Correct.
If you are able to bring pressures down, you impact mortality, impact target organ damage to a larger extent. Yes, all these factors are very important, that metabolic effects, other things, concomitant disease get, but the pressure coming down, the AllHat, which was the largest study actually with 40,000 individuals, showed us that diuretics, in fact, it scored better than lisinopril and amlodipine because the blood pressures were brought down to 1 millimeter, 1.5 millimeters lesser than the other.
So my honest concern was, especially in asking you about the elderly, is the amount of the hyponatremia, bestowing abilities that especially this thiazide or thiazide-like diuretics they have in comparison to loop diuretics. And that is the real area of the concern, even though, so that was what the reason why I asked you this question.
That should be always kept in mind. You're very
yes, yes.
In fact, these diuretics can mitigate the hyperkalemia when you are adding ACE inhibitors, ARBs. And also, you see, you need to choose your patients well. In summer months, like in Delhi, when the temperature hits 42, starting a diuretic in an individual may be producing much more hyponatremia than in the winters when these patients are eating more and there's lots of sweating. So I think the other factors, as has been mentioned again and again, are very, very important. Diuretics and calcium channel blockers act at the mechanism of action in the elderly. That is that they act at the salt sensitivity, while beta blockers, ACE inhibitors, ARBs will be much more effective when you have a younger individual. And very rightly pointed out that young patient with anxiety, with migraine, with CAD, I think beta blockers would still have a place, as pointed out by Dr. Hunter.
I think we have come to an end. We would take up a few questions that we've got in the chat box. The President, sir, may I request you to take up a question, one or two?
One question in chat box is, what about hyponatremia with diuretics? It's the one question which I can see in the chat box.
I think it is.
And secondly,
yes.
Is better thiazide or indapamide?
So indapamide is a very, very good, effective, long-term and a long-acting drug. And it's a very good, a combination of ACE inhibitors, ARBs and indapamide can mitigate the side effects of each other. As far as hyponatremia is concerned, we've already discussed that we need to individualize the patient. If the patient has a volume overload, if the patient has a high blood pressure which is not getting controlled with ACE inhibitors, ARBs, and as a third line agent, it should be used. But yes, an elderly, lean and thin, who's very low in weight, has frailty, we must make them understand that you need to monitor your electrolytes regularly, especially when you are on long-term diuretics, and especially any history of fall or hyponatremia should make them stop the drug. Sometimes we, in the Western countries, resort to urinary sodium to try to understand how much is the direct effect, but it is not of use in practical terms.
Great. Thank you very much. I think we've come to an end. We've had fantastic 1.5 hours of discussion, and I would request President sir to give a concluding remarks.
Thank you, Agam. I think we had a wonderful discussion this evening, and it made World Hypertension Day for us. A very sincere thanks to Dr. Wander, Dr. K K Pareek, Dr. N P Singh, Dr. Shashank Joshi, Dr. Kamlesh Tewary, Dr. Mangesh Tiwaskar for their masterly comments, and to every one of you to join this evening. Thank you so much. Agam, you for water, thanks.
Thank you, everybody. all guest faculties. Mangesh, I tried giving you that difficult question, but you answered so well. Was there a paper leak? Did you get those questions beforehand? I
Yes,
need
I
to know
must be
that.
honest that, Girish has already forwarded me those questions.
Thank you, everybody. I
Dr.
thank
Wander,
President
I
sir
have
for
got just a
the.
minute. Dr. Wander, I have got one
Sir.
question for you. I mean,
Sir.
just in the elderly patient, we know that systolic hypertension is more important from the point of view and organ damage. Now, as you reduce the blood pressure, systolic blood pressure, there is a great reduction of diastolic blood pressure, even up to the extent of 60 or 55 or 45. Now, at below 60, below 70 or 65, there is a chances of cardiovascular event. So what should be done in such cases?
Now I think Mangesh should have no such grudge with Agam that he was asked the most difficult question. I think after this, so that grudge is gone, Mangesh.
Thank you, sir. Thank you.
Yes, sir. This is actually the most catch 20 situation in which you are absolutely right that diastolic blood pressure was brought into limelight in 2018. And for the last 50, 60 years, actually, we have been discussing the J-shaped curve. Initially, the Cruikshank actually published this data and brought it into actually people's knowledge. And then it was debated for a long period of time. People said nothing exists like a J-shaped curve. And then it has revisited now. What is very important is someone has a coronary artery disease and it's this non-revascularized coronary artery disease. The coronary steel is more important in them. If it's a young patient, this diastolic pressure coming low, and as Sir is saying, actually this issue starts in the elderly. So you will have to have, if it's a CAD patient, if your patient is developing postural symptoms, having symptoms due to diastolic pressure being low, watch it. Otherwise, the systolic blood pressure is, as they say, more difficult to treat, more resistant, more often needs multiple drugs, and the systolic blood pressure actually needs to be. If you remember, the GNC actually 8 mentioned higher systolic and diastolic pressures to be accepted. In fact, one of the biggest criticism of GNC 8, which was the last GNC, was they said 150 systolic. Yes. So blood pressure needs to be brought to, and now we have data from the Hayward trial, which was done in octogenarians 80 plus, that the blood pressure reduction benefit is as much in the elderly as in the non-elderly. So first endeavor should be, if the patient is not symptomatic, bring their systolic blood pressures to 140 to 150, as we have mentioned in our guidelines. If the diastolic pressure goes down, your patient has coronary steel, is non-revascularized, then possibly you will compromise at a little bit higher level. But most important is the level of pressure which needs to be brought down to 140 to 150.
Thank you,
Great.
sir. Thank you very much.
I'm sure when Wander sir gives his time, and I'm sure when there is such an interesting discussion on topic which is of interest to everybody, hypertension going on, nobody would want to leave stage. But I think I'm getting signals from Bijal. The Kamwali Bai is come, dinner is pending. I may have to wash utensils myself. So I would request everybody to please sign off. Thank you very much for your presence. Thank you, Wander sir. Thank you, every faculty for here and every delegate for joining here, being here and making it so interactive. Thank you.
Thank you.
Bye-bye. Good
Thank
night.
you.
Thank you very much, Agam, and the entire